1, 2,
and review 70-year-old female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this this expectation of absolute precision, like engineering.
Right, yeah. Like it should be a math equation.
Exactly. You break your arm, you go to the ER, the x-ray shows that jagged white line on the black background, and the doctor just points and says, you know, there it is.
It's comforting because it's localized. I mean, you fix the bone, you fix the problem.
Right. It's clean. You can physically point to it. But then you step into FT's room.
Yeah, FT is where that comforting illusion of like localized medicine just completely falls apart.
It totally does. You step into his room in the ICU, and that clean binary x-ray machine mindset is completely useless. You are stepping into the shoes of an intensivist right now, walking through those glass doors, and you see him.
And you have to look at the whole picture immediately.
Right. So FT is a 70-year-old man. He has a 30-pack-year smoking history. He's got chronic obstructive pulmonary disease, COPD, heart failure, hypertension. And he presents with 3 days of progressively worsening shortness of breath.
Which is a terrifying combination of underlying issues.
It really is. And you look at the monitor, his oxygen saturation, his SpO2, is 87% on room air. He's breathing 30 times a minute.
Oh, wow. Yeah. That's fast.
He's hunched over a table, you know, using every muscle in his neck and shoulders just to drag air into his lungs.
Wow.
And when you listen to his chest, it sounds like wet bubble wrap. Just bilateral crackles everywhere.
Yeah, he's in serious trouble.
You have exactly 5 minutes to figure out which part of his respiratory cascade is collapsing before he codes.
Because with FT, you aren't fixing a broken bone. You are trying to intervene in an active avalanche of failing physiology.
That's a great way to put it. An avalanche.
Yeah, and to save his life, you have to master the exact sequence of events, from cellular collapse in the alveoli all the way up to total hemodynamic compromise.
So we can't just look at a list of symptoms and treat them blindly.
Exactly. We have to understand the underlying physical laws, the physics, the fluid dynamics, the cellular signaling that are actively driving this man toward respiratory arrest.
Okay, so let's pause the clock in FT's room for a second. Because before we can save him, we really need to understand what normal looks like. But not the textbook normal, right? We need the 80-20 rule of the respiratory system.
Right, let's get down to the core of it.
So what is the fundamental non-negotiable purpose of these organs?
The absolute primary purpose is gas exchange. I mean, that's it. We're transferring oxygen into the blood to fuel cellular metabolism, and we're transferring carbon dioxide, the exhaust gas, out of the body.
The exhaust gas, I like that.
But here is the critical concept that trips up so many people, especially on exams. Oxygenation is a two-part supply chain. It absolutely depends on a healthy, open respiratory structure to get the air into the microscopic sacs, the alveoli.
But that's only half the battle, right?
Exactly. It equally depends on adequate perfusion. You have to have blood flow to carry that oxygen away.
So it's like the delivery truck is useless if the loading dock is open, but the highway is totally washed out. Right. And vice versa. I mean, you can have the most pristine, perfectly functioning lungs on the planet, but if your heart isn't pumping blood past those alveoli to pick up the oxygen, you will still suffocate.
And the sheer scale of this biological loading dock is just staggering to me. I was looking at the notes for this deep dive, and the adult lung has over 300 million of these tiny alveolar sacs.
It's incredible architecture.
It really is. If you took them all and flattened them out, you'd have a surface area roughly the size of a tennis court packed inside your chest cavity. That is an unbelievable amount of delicate tissue.
It is, but it has a massive design flaw.
Oh, like what?
Well, it's a structural paradox. Because those alveoli are essentially tiny wet balloons.
Yeah.
And if you remember basic physics, water molecules like to stick together.
Right. There's surface tension.
Exactly.
Right.
That creates surface tension. If you take two wet panes of glass and stick them together, it is incredibly difficult to pry them apart.
They just suction right onto each other. Yeah, and that same surface tension exists inside every single one of those 300 million alveoli. Left to their own devices, they naturally want to collapse inward and snap shut.
Wait, so the whole tennis court wants to just collapse?
Yes. The only thing preventing a tennis court's worth of lung tissue from collapsing every time you exhale is a lipoprotein called surfactant. It acts like a biological detergent.
Like soap breaking the tension.
Right. It lowers that surface tension, keeping the balloons slightly inflated even when you breathe out, so they're easy to expand on the next breath.
But FT is 70 years old. His body isn't, manufacturing things the way it used to, and his structural integrity is changing. He's at peak risk just by virtue of his age, isn't he?
Absolutely. Gerontologic changes fundamentally alter the mechanics of breathing. Think about the rib cage. It's supposed to be this flexible, dynamic bellows system.
Expanding and contracting.
Yeah, but as we age, the costal cartilage, the connective tissue attaching the ribs to the sternum, begins to calcify. It turns from flexible gristle into stiff bone.
Oh man, so he's essentially trying to inflate his lungs inside a rigid, calcified cage.
And the lungs themselves lose their elastic recoil. They become baggy. He literally has fewer functioning alveoli than he did at 30.
So everything is just stiffer and less efficient.
It gets worse. Perhaps the most dangerous gerontologic change is neurological. Our central chemoreceptors, the sensors in the brain that monitor our blood gases and tell us to breathe, they become blunted.
They lose their sensitivity.
Yeah. When oxygen levels drop, a young person's brain sounds a massive alarm. FT's alarm system is muffled. He can drift into dangerous hypoxemia before his brain really registers the panic.
Okay, so we've got a calcified cage, baggy lungs, and a broken alarm system. That's a bad setup.
A terrible setup.
To really understand how to assess him, we need to internalize a few foundational facts about how air actually moves. Let's talk about anatomic dead space, because this blew my mind.
Yeah, this is a crucial concept for understanding why rapid, shallow breathing is so lethal. When you take a normal resting breath, you pull in about 500 milliliters of air. We call that the tidal volume.
500 milliliters, okay.
But not all of that air reaches the alveoli where gas exchange happens. About 150 milliliters of it just fills the plumbing, the trachea, the bronchi, the larger airways.
It's just sitting in the pipes and never even gets to the loading dock.
Exactly. It never participates in gas exchange. It is dead space. Now, if you are taking healthy, deep breaths, that 150 milliliters is a minor tax. You're still getting plenty of fresh air deep down.
But imagine a patient in pain or in heart failure, like FT, who starts taking very rapid, very shallow breaths of only, say, 200 milliliters.
Right, let's do the math on that.
Right. If they take a 200 milliliter breath and the dead space tax is 150, they're only getting 50 milliliters of fresh air to the alveoli.
Exactly. They might be breathing 40 times a minute, looking like they are working incredibly hard, but they are effectively suffocating.
Because all they are doing is moving air back and forth inside the dead space plumbing. None of it is actually reaching the alveoli.
You got it. That completely changes how you look at a patient breathing fast. You can't just say, well, air goes in, air goes out, they're fine. You have to think about the depth.
That is so important. Let's move to the second structural fact, which involves the pores of Kohn. I found this absolutely fascinating in the source material. It's like a secret underground network.
They are, yeah. They're microscopic connections, little windows between adjacent alveoli. If you have a cluster of these tiny balloons, the pores of Kohn allow air to move laterally between them.
So if a mucus plug blocks the main airway leading to one specific balloon, it's not totally doomed.
Right, collateral ventilation.
Mm-hmm.
Air can sneak in through the side door from the neighboring alveolus to keep it inflated, and taking deep breaths, or specifically deep sighs, helps pop these pores open and force air through them.
Which helps prevent sections of the lung from collapsing. But they have a dark side, don't they?
Unfortunately, yes.
I was reading this, and it struck me like a biological air ventilation system that unfortunately also acts as a burglar tunnel for bacteria.
That's a perfect analogy. It's a fatal flaw in the architecture when it comes to infection. Normally, if a pathogen gets into an alveolus, the immune system's instinct is to wall it off, trap it.
Keep it contained.
But bacteria, particularly pneumococcal bacteria, use these pores of Kohn as highways. They march right through these microscopic windows, spreading the infection from one alveolus to the next.
Wow, turning a tiny localized infection into a massive lobar pneumonia that sweeps across the entire lung.
Exactly. So our biology is literally facilitating the spread of the infection to keep the air flowing.
That's wild. Okay, that brings us to surfactant again. We know it lowers surface tension, but it doesn't just sit there passively, right?
No, surfactant requires mechanical stretching to be secreted by the specialized type II cells in the alveoli. This is why human beings naturally take a slightly deeper sigh every 5 or 6 breaths.
Usually without even being aware of it. Just a tiny, unconscious stretch.
Right. That stretch physically signals the cells to release more surfactant, coating the inside of the balloon and keeping it open.
So what happens when someone stops doing that?
Well, when a patient is sedated, or in severe pain, or has broken ribs, they stop taking those deep sighs. The surfactant depletes, the surface tension spikes, and the alveoli collapse.
Boom, atelectasis. Okay, and the final anatomical fact we need before we get back to FT is about the actual branching of the windpipe, because anatomy dictates pathology here.
It really does. If you look at the trachea coming down into the chest, it bifurcates, it splits into the right and left mainstem bronchi, but it's not a symmetrical split.
Right, because of the heart.
Exactly. To make room for the heart on the left side of the chest, the left bronchus takes a sharper, more horizontal angle. The right mainstem bronchus, on the other hand, is shorter, wider, and much straighter.
It's almost a direct downward continuation of the trachea.
Yes. So it's the path of least resistance, which means if FT were to vomit and aspirate stomach contents or inhale a piece of food.
Gravity and airflow will almost always pull it down into the right lung.
Exactly. When you see a patient with sudden pneumonia isolated in the right middle or lower lobe, your brain should immediately think, aspiration. They inhaled something they shouldn't have.
That makes perfect sense. Okay, we have the biological blueprint. We know the failure points. Let's go back to FT's room. He's struggling to breathe. We need to look at the pathophysiology, the cascade of failure. What triggered this crisis?
Well, FT's history gives us the trigger. He told the triage nurse he thinks he caught a cold from his granddaughter a few days ago.
Just a simple cold.
Right, but that viral infection triggered an inflammatory response in his respiratory tract. In a healthy person, a cold is an annoyance. In a 70-year-old with damaged COPD lungs, it is the first domino in a lethal cascade.
Because his airways are already compromised, and now inflammation is making them swell shut.
That's the first major problem. Drastically increased airway resistance, the pipes are narrowing, but we have a dual threat here. FT also has a history of heart failure.
Right.
His heart is a weak pump. When he gets sick, the physiological stress puts more demand on that pump, and it begins to fail.
And when a pump fails, fluid backs up.
Specifically, it backs up into the pulmonary circulation. The pressure inside the pulmonary capillaries, the microscopic blood vessels wrapping around the alveoli, begins to rise. We call this hydrostatic pressure.
It pushes outward against the vessel walls.
Yeah, and eventually the pressure gets so high that blood plasma is physically forced out of the blood vessels into the interstitial tissue spaces and eventually floods right into the alveoli themselves.
Pulmonary edema. His lungs are literally filling with water from the inside out.
And think about what happens when a massive amount of fluid washes into an alveolus. It washes out, dilutes, and inactivates whatever surfactant was left.
Oh man, so we have the trifecta of doom here. The pipes leading to the loading dock are swollen shut due to COPD and viral inflammation.
Yep.
The loading dock itself is flooded with fluid from the failing heart, and the chemical that keeps the structure from collapsing has been washed away.
Exactly. But the body doesn't just passively accept death. It attempts to compensate. And this compensation is driven by deeply ingrained neurological reflexes.
The receptors. How does his brain even know he's drowning?
We have central chemoreceptors located in the medulla of the brain. Now, you would think they measure oxygen, right? To see if you're suffocating.
Yeah, that would make sense.
But evolution engineered them differently. The central chemoreceptors are acutely sensitive to carbon dioxide.
Not oxygen.
Nope. Specifically, the hydrogen ions that are created when CO2 mixes with water in the blood and forms carbonic acid. When FT stops ventilating effectively, his CO2 rises. His blood becomes acidic.
And the brain detects that.
Yes. The central chemoreceptors detect this rising acid and send panic signals down the phrenic nerve to the diaphragm. Breathe faster, breathe deeper. Get rid of this exhaust gas.
But that's just the chemical side, right? There's also a physical alarm system inside the lungs themselves.
Right, the J receptors, or juxtacapillary receptors. These are mechanical stretch and pressure sensors embedded directly in the alveolar walls, right next to the capillaries.
Okay.
When FT's heart failure causes fluid to engorge those capillaries and leak into the tissue, the J receptors physically feel that swelling and pressure.
They sense the flood.
And when triggered, the J receptors initiate a very specific, uncontrollable reflex. Rapid, shallow breathing.
Tachypnea.
Wait, rapid shallow breathing. But we just established that shallow breathing is terrible because of the dead space tax. Why would the body trigger a reflex that makes gas exchange worse? It's an evolutionary desperation move. When the lung tissue is engorged with fluid, it becomes incredibly stiff. It loses its compliance.
So it's hard to stretch.
Right. Trying to take a deep breath into a stiff, fluid-filled lung requires a massive amount of muscular force, more force than the body can sustain. So the brain opts for rapid, shallow breaths because it's mechanically easier in the short term.
Even though it's physiologically disastrous in the long term due to the dead space, it's trading efficiency for mechanical survival just to keep moving air.
Exactly. But eventually, that compensation hits a wall. We reach decompensation.
And what does that look like?
The mechanical work of breathing simply outpaces the oxygen being delivered. FT's diaphragm is contracting 30 times a minute against heavy resistance. The muscles themselves are burning huge amounts of oxygen.
Oh, I see.
At a certain point, the work of breathing consumes more oxygen than the lungs can physically extract from the air.
The rescue operation is burning more fuel than it's saving.
Perfectly said. His diaphragm, which is a skeletal muscle, begins to fatigue. It starts to tire out, just like your legs would if you ran a marathon.
And this cellular and muscular failure translates directly to what we see standing at the foot of FT's bed, the clinical findings.
Yes, what do we see?
We see retractions. The muscles between his ribs and above his clavicles are violently sucking inward with every breath. We see cyanosis, that terrifying bluish tint to the lips and nail beds, signaling profound hypoxemia, a lack of oxygen in the blood.
And we see the classic tripod position. He's sitting on the edge of the bed, leaning forward, resting his forearms firmly on the overbed table.
Why does every patient in respiratory distress instinctively do this? Is it just panic?
No, it is pure mechanical optimization. By leaning forward and planting his arms on a fixed surface, FT is physically locking his shoulder girdle and pectoral muscles into a stationary position.
Okay, so his arms are anchored.
Right. This gives his accessory muscles, the sternocleidomastoid in the neck, the scalenes, the pectoralis minor, much better leverage. Instead of moving his arms, those muscles can now pull upward on the rib cage from a fixed anchor point.
Violently prying the chest cavity open to create negative pressure.
Yes. He is using his neck and chest muscles as a crowbar to force air into his rigid lungs.
That is terrifying to watch. Okay, so we're assessing him, we're hunting for clues. If we back up a bit, before a patient gets to this critical tripod stage, what are the early signs? The whispers before the alarm bells?
Early findings of hypoxia are almost always cardiovascular and neurological. The brain senses the dropping oxygen and triggers a sympathetic nervous system response, an adrenaline dump.
So we see tachycardia. FT's heart rate is pounding at 110 beats per minute.
The heart is trying to pump the poorly oxygenated blood faster to compensate. We also see mild hypertension. FT's at 170/90. The vessels clamp down.
And mentally, how is he doing mentally?
Restlessness, irritability. The patient can't get comfortable. They might be constantly shifting in bed, picking at their sheets, or getting short-tempered.
And a novice nurse might think the patient is just anxious or having a behavioral issue.
Exactly. But an intensivist knows that unexplained restlessness is the brain screaming for oxygen.
Then we move into the classic findings, the ones that are obvious from the doorway.
Tachypnea. 30 breaths a minute. The accessory muscle use in the neck, the tripod position. But look closer at his breathing pattern. You'll see prolonged expiration.
Prolonged expiration. How so?
In a healthy person, the ratio of inspiration to expiration is about 1:2. It takes twice as long to breathe out passively as it does to breathe in actively.
Okay.
But FT has COPD and viral inflammation. His lower airways are narrowed and filled with mucus. Air goes in somewhat easily because the chest expands, pulling the airways open.
But coming out is the problem.
Right. When he tries to exhale, the chest compresses, and those weakened, narrow airways collapse. He has to forcibly push the air out against massive resistance.
So that 1:2 ratio becomes stretched out.
He spends agonizing seconds just trying to force the stale air out so he can take the next breath.
And if we don't intervene here, if we don't fix the resistance and the fluid, we descend into the late, dangerous findings.
This is the brink of death, cyanosis. The restlessness transitions into combativeness or profound confusion as the brain actually begins to starve, eventual coma.
And his blood pressure.
Hypotension, as the heart muscle itself, deprived of oxygen, finally tires out and the blood pressure drops.
And then there's the clinical sign that should make every critical care nurse's blood run cold: abdominal paradox.
If you only remember one physical sign of impending doom, let it be abdominal paradox. Normally when you inhale, the diaphragm contracts and moves downward, pushing the abdominal contents out. Your belly goes outward when you breathe in.
Right, everyone can test that right now.
But in FT, his diaphragm has been working at maximum capacity against stiff lungs for days. It is exhausted. It physically gives up.
So what happens?
When the diaphragm fails, FT relies entirely on his chest and neck muscles to pull the rib cage up. This creates a massive negative vacuum in the chest because the diaphragm is now just a flaccid piece of meat. That vacuum literally sucks the diaphragm and the abdominal contents upward into the chest cavity.
So when he tries to breathe in, his belly forcefully pulls inward.
Yes. His chest expands, but his stomach caves in. It is a massive red flag signaling catastrophic, irreversible diaphragm fatigue. If you see abdominal paradox, the patient is going to stop breathing entirely in a matter of minutes. You are about to be doing chest compressions.
Okay, let's do the focused respiratory assessment. We need to physically touch his chest. Palpation and auscultation. I want to spend some time here because the physics are really fascinating.
It is, yeah.
You place your hands flat on FT's back, over his lower lobes, and you ask him to say a deep resonant phrase like toy boat or 99. You are checking for tactile fremitus.
Right. Tactile fremitus is the vibration of the vocal cords transmitted down the bronchial tree through the lung tissue to the chest wall and into your hands.
Now, in FT's case, because his lower lobes are filled with pulmonary edema fluid from his heart failure and consolidation from the pneumonia, you will actually feel those vibrations increase. They get stronger against your hands.
Yes.
I've always found this counterintuitive. Why does a lung filled with liquid make the sound louder? Shouldn't it muffle it?
It's all about acoustic physics. Sound waves travel much faster and more efficiently through a solid or a dense liquid than they do through a gas. Think about being underwater in a swimming pool. You can hear someone bang on the ladder from across the pool perfectly.
Because water is denser.
Exactly. Normally, a healthy lung is mostly air. That air acts as an acoustic insulator. It dampens and scatters the vibration of the vocal cords before it reaches the chest wall.
Okay, I see.
But when FT's alveoli become flooded with fluid and consolidated with inflammatory debris, that spongy, air-filled tissue becomes dense and solid. It creates a direct, high-speed acoustic bridge from his vocal cords straight to your fingertips.
The vibration is transmitted powerfully. So increased tactile fremitus means there is density or fluid inside the lung tissue.
Precisely.
Okay, but what if that fluid is outside the lung? What if the heart failure caused fluid to leak into the pleural space, the cavity between the lung and the inside of the rib cage, a pleural effusion?
This is the genius of the physical exam. If the fluid is outside the lung in the pleural space, the fremitus dramatically decreases or disappears completely.
It's still fluid, right?
Because the fluid is no longer inside the transmitting tissue acting as a bridge. It is now acting as a moat. It pushes the actual lung tissue away from the chest wall. The sound travels down the lung, hits the edge of the lung, and then hits a wall of fluid that is physically separating the vibrating tissue from your hands. Location is everything. Inside the lung, louder. Outside the lung, muffled.
That completely changes how I think about placing my hands on a patient. And when we use the stethoscope to auscultate, we are listening to this exact same physics. FT has a symphony of failure happening in his chest. Let's talk about the lung sounds. First, fine crackles.
Fine crackles sound exactly like taking a lock of dry hair and rolling it between your fingers right next to your ear. It's a high-pitched, delicate popping.
And what's making that noise?
What you are hearing is the sound of thousands of sticky, collapsed alveoli suddenly snapping open at the very peak of inspiration, overcoming that surface tension we talked about.
Then we hear coarse crackles.
Coarse crackles sound much lower pitched and wetter, like blowing bubbles through a straw into a glass of milk. This is the literal sound of inhaled air violently churning its way through pools of fluid and thick mucus in the larger airways, the bronchi.
And finally, wheezes.
A high-pitched musical sound. This is the sound of air being forced at high speed through bronchial tubes that have been severely narrowed by inflammation and muscle spasms. Just like pinching the neck of a balloon while letting the air out makes it squeak.
So we have the physical picture. Now we need the hard data. We are moving into diagnostics, the hemodynamic arsenal.
The numbers.
We draw FT's labs. His white blood cell count is 17,350. Normal is around 5 to 10,000. So his immune system is mounting a massive defense against this viral and secondary bacterial infection. But then we see his potassium. It is 2.9 milliequivalents per liter.
Normal potassium is 3.5 to 5.0. A potassium of 2.9 is severe hypokalemia. And in a patient whose heart is already beating at 110 times a minute, this is a ticking time bomb for a lethal cardiac arrhythmia. We will definitely come back to this, but it is a massive constraint on our treatment plan.
We also pull an arterial blood gas, an ABG. We puncture the radial artery in his wrist to see exactly what the blood leaving the heart looks like. The results show compensated respiratory alkalosis with severe hypoxemia. His PaO2, the partial pressure of oxygen physically dissolved in the arterial blood, is less than 40 millimeters of mercury. Normal is 80 to 100.
Less than 40 is profound, life-threatening hypoxemia. His tissues are suffocating.
But wait, if we look at the monitor above his bed, the little glowing pulse oximeter on his finger says his SpO2 is 87%. 87% sounds bad, but it doesn't sound like less than 40 millimeters of mercury bad. Why is there a disconnect?
This brings us to a massive fundamental distinction in critical care monitoring: SpO2 versus ScVO2. The pulse oximeter on the finger, the SpO2, is measuring arterial saturation. It shines a light through the tissue and calculates the percentage of hemoglobin molecules that have oxygen attached to them.
Okay, so 87% of his hemoglobin is carrying oxygen.
Yes, but the SpO2 monitor has massive deadly blind spots. First, the technology becomes highly unreliable once the saturation drops below 70%. It just loses accuracy.
Right.
Second, it requires pulsatile blood flow in the finger to read correctly. If a patient is freezing cold or in severe cardiogenic shock, or if they're on high-dose vasopressor medications like Levoft that clamp down all the blood vessels in the extremities to shunt blood to the core.
The finger isn't getting any blood flow anyway.
Exactly. The monitor might throw a random number, or it might show a beautiful 99% because it's reading the same stagnant blood over and over.
Right.
You could have a normal SpO2 while the patient's internal organs are actively dying of ischemia. It only tells you what is leaving the heart, not if it's actually reaching the tissues or being used.
So if the pulse ox is lying to us, or at least only telling half the truth, how do we know if the cells are actually getting the oxygen they need to survive? What's the alternative?
We look at the venous side. We look at the ScVO2, or central venous oxygen saturation. This is the ultimate ICU metric. We don't use a finger clip. We draw this blood directly from a central line catheter, the tip of which sits deep in the chest, right above the heart in the superior vena cava.
So this is blood that has already made the full trip. It left the heart, went to the brain, the muscles, the organs, dropped off oxygen, and is now on its way back to the lungs for a refill.
Precisely. A normal ScVO2 is between 60% and 80%. This means the blood left the lungs at 100% full. The body consumed about 20% to 30% of that oxygen for normal metabolic function, and the blood returned 70% full. What the ScVO2 measures is the delicate balance between oxygen delivery and tissue consumption.
It's like checking the exhaust pipe of a car engine to see how efficiently the fuel is burning rather than just checking the gas tank.
That is exactly what it is. If FT's ScVO2 drops below 60%, it means his tissues are starving. They're in distress, because either his failing heart isn't delivering enough blood volume or his metabolic demand is wildly out of control.
And with FT, his demand is huge right now.
Think about it. He has a fever from the infection, his heart is racing at 110, and his respiratory muscles are doing the equivalent of a deadlift 30 times a minute. His body is burning through oxygen at an astronomical rate.
So the cells are just sucking it all up.
When the blood finally returns to the central line, it has been stripped bare. The cells have extracted every last possible molecule of oxygen out of desperation. A dropping ScVO2 is a scream for help from the cellular level.
Man, that's intense. We also use capnography, or PEC2. This measures the end-tidal carbon dioxide in his exhaled breath. It gives us a real-time, breath-by-breath look at how well he is ventilating, how well he is getting rid of the exhaust.
Yes.
And finally, imaging. His chest X-ray comes back. It confirms our physical exam. An enlarged cardiac silhouette, proving his heart failure is acting up, and bilateral patchy opacities in the lower lobes. His lungs are flooded with pneumonia and edema.
Now we transition from gathering clues to clinical reasoning. How do we synthesize this chaos? We use ADPIE, assessment, diagnosis, planning, implementation, and evaluation.
We prioritize. FT is presenting with a deadly triad.
You walk in, and you instantly recognize this combination. And SpO2 of 87%, an irregular tachycardia of 110 beats per minute, and severe accessory muscle use with a respiratory rate of 30. That triad means one thing: impending fatigue and respiratory arrest.
So our highest priorities, our nursing diagnoses, aren't the fever or the cough. The primary problems are impaired gas exchange because of the fluid flooding the alveoli and an ineffective breathing pattern because his muscles are fatiguing against the swollen airways.
Which dictates our goals.
Right.
We need measurable targets. We want his SaPO2 above 90%. We want to see his respiratory rate drop below 24, not because he's tired, but because his work of breathing has genuinely decreased. We want to see those accessory muscles in his neck relax. And most importantly, we need that ScVO2 to rise back above 60%, proving his cellular starvation is ended.
To get there, we initiate priority nursing actions. What happens first, next T, and then?
The absolute first thing you do requires no doctor's order. You physically reposition the patient. You get FT upright, sit him on the side of the bed, leaning over a table in that tripod position.
Why is positioning so powerful?
Gravity. When he sits up, gravity pulls all that pulmonary edema fluid down into the lower bases of his lungs. This instantly frees up the dry, healthy alveoli in the upper lobes to start exchanging gas.
Wow, just sitting up does that.
It also allows gravity to pull the abdominal organs downward, dropping the diaphragm fully so it has room to expand. And simultaneously, you apply supplemental oxygen to immediately treat that SpO2 of 87%. And you ensure his airway isn't physically blocked. Oxygen and gravity. Next, we obtain the diagnostics. We grab the ABG, we draw the baseline ScVO2 from the central line, but we also immediately get a 12-lead ECG. Why an ECG if this is a lung problem?
Because you have to ask why his heart failure suddenly flared up. Did the viral infection cause it, or did he have a silent heart attack, a myocardial infarction that damaged the pump and caused the fluid to back up into the lungs? The ECG rules out cardiac ischemia as the root cause.
Then, and only then, we hit him with the medications. We administer targeted drugs to fix the resistance and the compliance.
Let's look at our pharmacological weapons. First up is albuterol. This is a short-acting beta-2 agonist, a bronchodilator. It binds to receptors in the lungs and forces the smooth muscles wrapped around the airways to relax, opening the pipes. But here's a critical detail in the case study. FT told the triage nurse that he took his albuterol inhaler at home and it stopped working.
Novices will just assume he needs a higher dose. An intensivist recognizes this as a terrifying clinical clue. If the albuterol isn't working, it means the airways are so severely inflamed, so swollen with mucosal edema, or so completely plugged with thick mucus that the aerosolized drug physically cannot travel down the pipes to reach the receptors. The door is barricaded.
Next on his home medication list is Advair. That's a combination of fluticasone and salmeterol.
A maintenance inhaler. It contains a long-acting steroid and a long-acting bronchodilator. It is completely useless in this acute emergency. It takes hours, sometimes days, to reach peak effect. Do not waste time giving maintenance meds when the patient is actively dying.
So we need the heavy artillery. The cornerstone drug to fix his fluid overload is furosemide, commonly known as Lasix.
It is a potent loop diuretic. It works on the kidneys to aggressively dump sodium and water. We use it to pull that massive volume of fluid out of his interstitial lung spaces and alveoli, forcing him to urinate it out. As the fluid drains, his lungs will become lighter, softer, and more compliant. The work of breathing will plummet.
But here's the massive catch-22 of this case, the ultimate exam trap and clinical nightmare. We are giving him a drug to fix his lungs that could very easily stop his heart.
This goes back to his lab results. His potassium is 2.9.
Look, furosemide doesn't just waste water and sodium, it heavily depletes potassium in the urine. If you push a massive dose of intravenous furosemide into FT right now, you will drop his potassium from 2.9 down to 2.5 or lower.
And potassium is the electrolyte responsible for the resting electrical membrane potential of a heart cells. When potassium drops that low, the heart tissue becomes incredibly irritable. FT's heart is already racing at 110 beats per minute under immense stress. Severe hypokalemia will trigger lethal ventricular dysrhythmias, ventricular tachycardia, or VFib.
So you will successfully cure his pulmonary edema by throwing him into cardiac arrest.
Yes.
So what does the intensivist do? You can't let him drown in his own fluids, but you can't stop his heart.
You collaborate instantly with the provider. You demand orders to administer intravenous potassium alongside, or ideally slightly before, the aggressive diuresis. You replace it as fast as you waste it, and you keep his eyes glued to the cardiac monitor.
And a quick pearl regarding his medical history. He has hypertension. While it's not listed on his current active meds, a very common first-line drug for blood pressure is an ACE inhibitor like lisinopril.
It is vital to know that a hallmark side effect of ACE inhibitors is a dry, persistent hacking cough caused by a buildup of a chemical called bradykinin in the lungs. When any patient presents with a respiratory complaint and a cough, you must always look at their med list to differentiate a harmless drug side effect from a developing heart failure, exacerbation, or infection.
So we're giving the bronchodilators, we are carefully diuresing with Lasix, we are replacing the potassium.
Ooh.
But what if it's not enough? What if the fluid has pooled into spaces the drugs can't reach? Let's talk procedures. Inside the ICU.
Right.
If FT develops a massive pocket of fluid in the pleural space, that moat outside the lung we talked about earlier, diuretics won't drain it fast enough, he might need a thoracentesis.
This is a mechanical solution to a mechanical problem. A provider inserts a large bore needle through the patient's back, directly into the pleural space, and physically vacuums the fluid out into a canister.
How do we prep him for a needle going into his back?
The exact same way he is positioned now. You have the patient sit upright on the edge of the bed, leaning forward, resting his arms and head on the overbed table. This position optimally spreads the ribs apart, opening the intercostal spaces so the needle can cast through without hitting bone.
The major complication here seems obvious. You are sticking a sharp needle millimeters away from an inflated lung.
The risk is a pneumothorax, accidentally puncturing the visceral pleura, the outer lining of the lung. If that happens, air leaks out of the lung into the chest cavity, collapsing the lung itself.
So what's the nursing action there?
Therefore, the non-negotiable post-op nursing action is to immediately listen to breath sounds in all lung fields to ensure air is still moving symmetrically and to get a stat chest x-ray to prove the lung is intact.
What if the problem isn't fluid outside the lung, but massive mucus plugs inside the airways that his albuterol can't penetrate, and he is too exhausted to cough up?
Then we perform a bronchoscopy. We thread a flexible fiber optic camera down his trachea into the bronchi, and we use tools to physically suction the mucus out or take tissue biopsies.
The prep for this involves conscious sedation and keeping him NPO nothing by mouth for 6 to 12 hours prior so he doesn't vomit while the camera's in his throat. But the post-op care is where nurses make critical mistakes.
The local anesthetic sprayed into the back of his throat paralyzes the gag reflex. You are dealing with cranial nerves 9 and 10, the glossopharyngeal and vagus nerves. The absolute priority post-procedure is that the patient remains strictly NPO until that gag reflex fully returns.
You must physically test it with a tongue depressor, right?
Yes. If a well-meaning nurse hands FT a cup of water or ice chips before those nerves wake up, the fluid will bypass the vocal cords and pour directly into his newly cleared lungs. Massive aspiration.
And finally, transthoracic needle aspiration, or TTNA. If they spot a suspicious mass on the X-ray, they might pass a needle straight through the chest wall to biopsy it.
This carries an extremely high risk of causing a pneumothorax, even higher than a thoracentesis. It is an absolute necessity to monitor breath sounds every 4 hours for at least 24 hours after this procedure.
Okay, we've stabilized the immediate crisis. Now we need to look at the numbers to see if we are actually winning the war. We are going into a hemodynamics and arterial blood gas deep dive. And this requires making a critical distinction that trips up so many people. Ventilation versus oxygenation.
They are intimately related, but they are not the same physiological process. Oxygenation is the act of getting oxygen molecules from the room air across the alveolar membrane and dissolved into the blood plasma. We measure this with the PA2 on the blood gas.
Ventilation, on the other hand, is purely the mechanical act of moving air in and out to blow off carbon dioxide. It is measured by the PaO2.
And FT is a perfect example of how these two processes can completely disconnect. FT is tachypneic. He is breathing 30 times a minute. Because he's breathing so rapidly, he's actually blowing off massive amounts of carbon dioxide. He is ventilating too much, which is causing his blood to become alkaline, or respiratory alkalosis.
But despite ventilating like crazy, he is still cyanotic and his PO2 is 87%.
Because oxygenation has failed. The mechanical bellows are pumping furiously, but the alveolar loading dock is underwater. Oxygen cannot diffuse through the thick layer of edema and pus in his lungs. He is overventilating, but severely under-oxygenating.
Which brings us back to the most fascinating nuance of this entire case, the SCVO2 monitor. Let's say we give him the Lasix, we clear some fluid, we give him oxygen. An hour later, we look at the central venous monitor, and his SCVO2 reads 85%. Normal is 60 to 80. So 85 means there is tons of oxygen returning to the heart. Is he better?
Not necessarily. In fact, an abnormally high SCVO2 can be a harbinger of cellular death. It can mean he is developing severe sepsis from his pneumonia.
Explain the mechanism there. Why does high oxygen in the vein mean sepsis?
In late-stage distributive shock, like sepsis, the bacterial endotoxins poison the mitochondria inside the cells. The mitochondria are the engines that burn oxygen to create energy. When they are destroyed, the cell loses the physical ability to extract and utilize the oxygen passing by in the capillaries.
So the delivery truck drives by, but the warehouse stores are locked.
Exactly. The oxygen stays bound to the hemoglobin, bypasses the starving tissues, and returns to the heart fully saturated. A high SCVO2 in a critically ill patient often means they are dying on a cellular level. They're starving to death in a grocery store.
That is haunting. The monitor looks fantastic, but the patient is crashing.
Let's pivot slightly to long-term monitoring. Pulmonary function tests, or PFTs. In a patient with a chronic obstructive disease like FT-COPD, we look closely at the FEV1 forced expiratory volume in 1 second.
It measures exactly what it sounds like, how much air he can violently exhale in the first second of a forced breath. Because FT's airways are structurally damaged, floppy, and prone to collapsing when under pressure from exhaling, his FEV1 drops sharply.
He simply can't get the air out fast enough.
Right. And in obstructive diseases, the ratio of FEV1 to total forced vital capacity is always less than 70%. It's the hallmark of COPD and asthma.
Let's talk about fluids and electrolytes, because we are constantly manipulating them in the ICU. There's a deadly dehydration trap in respiratory care. Yes, our airways are lined with a mucociliary escalator. These are millions of microscopic hairs, called cilia, that beat in a rhythmic upward wave. Their entire job is to sweep a sticky layer of mucus, which catches inhaled dust, viruses, and bacteria up out of the lungs to the throat, where it can be swallowed and destroyed by stomach acid.
We normally produce about 100 milliliters of this thin, lubricating mucus every single day.
But if a patient becomes dehydrated, maybe they have a fever. Or we over-diurese them that normal thin mucus loses its water content. It turns into a thick, dry, cement-like blanket.
And that heavy cement physically crushes the delicate cilia.
The escalator grinds to a halt. The bacteria trapped in the mucus are no longer being swept away. They stay in the warm, dark lungs, multiply rapidly, and trigger a massive pneumonia. Hydration is a primary respiratory defense mechanism.
Conversely, FT's immediate problem is fluid overload. We saw this with his 3+ pitting edema in his legs and his recent weight gain.
This overload increases the hydrostatic pressure in the vascular bed, which we know forces water backward into the delicate alveoli, drastically decreasing lung compliance.
And as we discussed, our treatment for the furosemide puts him at immediate risk for fatal arrhythmias due to his baseline hypokalemia of 2.9. We have to thread the needle perfectly. Okay, we've treated him, the diuresis is working, the potassium is replacing, but in the ICU, we don't just relax, we actively hunt for complications. Cause, finding, action.
Exactly.
Complication 1, tension pneumothorax.
The cause could be a procedure we just did, like the thoracentesis, or it could be barotrauma, meaning if we had to put him on a mechanical ventilator, the high positive pressure violently popped a weakened alveolus.
The find.
You will hear entirely absent breath sounds on one side of his chest, because the lung has collapsed into a tiny fist and the chest cavity is just filled with pressurized air, and the classic very late sign of this emergency. The trachea in his neck physically deviates away from the collapsed lung. The building pressure of the trapped air physically shoves the heart and the windpipe over to the opposite side of the chest.
The action.
This is a code blue. The patient will die in minutes from cardiovascular collapse because the pressure pinches the vena cava shut. You need an immediate needle decompression, stabbing a large needle into the chest wall to vent the trapped air, followed by a chest tube insertion.
Complication 2, atelectasis, which is localized alveolar collapse.
The cause: decreased surfactant, or shallow breathing, because it hurts to take a deep breath.
This goes back to our wet plastic bag analogy. The balloons get sticky and snap shut. The finding.
Find crackles upon auscultation, which is the sound of them popping open, and a dull thud when you percuss or tap the chest wall, because there's less resonant air in there.
The nursing action is aggressive mechanical force. Mobilize the patient, get them out of bed, force deep breathing exercises, and use an incentive spirometer, which is a device they suck on to physically force those sticky alveoli to peel open.
Yes, very important.
Complication 3, pleural effusion.
The cause is his heart failure, pushing fluid out, but this time into the intrapleural space, the cavity between the lung and the chest wall.
The finding.
As we discussed during our physics deep dive, absent tactile fremitus, dull percussion, and diminished breath sounds, because that fluid is acting as an acoustic shield, blocking the transmission of sound to the chest wall.
The action is usually a thoracentesis to physically drain the moat. Now, let's talk about the subtle art of recognizing deterioration. You have to know the answer to this critical question. The patient is getting worse if FT is getting worse if his respiratory rate drops from 30 to 12 without any medical intervention.
This is a classic trap for novice nurses. They see the frantic breathing slow down to a normal rate of 12, and they think, oh, thank goodness, the oxygen is working. He is relaxing. An intensivist sees that drop and knows his diaphragm is catastrophically fatigued. He isn't relaxing. He is actively transitioning into hypercapnic respiratory arrest. He simply doesn't have the energy to breathe anymore.
He is getting worse if you see that abdominal paradox, his belly sucking inward when he tries to inhale. That proves the primary breathing muscle has quit. He is getting worse if his ScVO2 drops steadily from 65% down to 50%.
That proves his metabolic demand is wildly outstripping his failing oxygen delivery. The cells are screaming for more fuel, and the heart can't provide it.
And you must watch his mentation closely. Patients move from being restless, anxious, and irritable.
Which, remember, are the early signs of brain hypoxia caused by the sympathetic nervous system.
Right, and they shift from restless to becoming somnolent, lethargic, or deeply combative.
That shift means profound late-stage hypoxia and building carbon dioxide narcosis. High levels of CO2 literally act as a sedative on the brain. When a restless respiratory patient suddenly becomes sleepy, they are not taking a nap. They are slipping into a coma.
This requires a clear escalation plan. Who do you call and when? You notify the provider for changes that require new orders but aren't immediately fatal. For example, if FT's SpO2 drifts from 95% down to 90%, or if he develops mild new confusion, or to report that critical potassium level of 2.9 to get the replacement orders before you get the diuretic.
But you trigger a rapid response or a code blue for catastrophic shifts. If his PO2 drops below 40, if his PO2 falls below 88% despite being on a high-flow oxygen mask, if you see the onset of abdominal paradox or that tracheal deviation we talked about, or if he becomes unarousable, those are signs of imminent death. You don't just pay the doctor, you hit the alarm.
Let's do some differentials and pattern recognition. How do we tell these diseases apart at the bedside? If you see prolonged expiration, hyperresonant percussion, meaning the chest sounds hollow like a drum when you tap it and you hear high-pitched wheezes.
Think asthma or severe COPD exacerbation. The underlying physiology is air trapping. The airways are narrowed, so air gets in, but it can't get out. The lungs become hyperinflated, which causes that hollow, drum-like sound.
If you see unequal chest expansion, dull percussion, and absent tactile fremitus.
Think pleural effusion, the moat. The fluid outside the lung is blocking movement and sound.
If you see tachypnea, dull percussion, increased tactile fremitus, and loud bronchial breath sounds down in the lower lobes where they shouldn't be.
Think pneumonia with consolidation. The lung itself is filled with dense, infected fluid, which transmits the vocal sounds perfectly to your stethoscope.
And a quick differential on tuberculosis testing, because context is everything in diagnostics.
A TB skin test relies on the immune system mounting a visible response, a hard bump called an induration. If a patient is highly immunocompromised, like someone with HIV, their immune system is very weak. So an induration of just 6 millimeters is considered positive for them. But that exact same 6 millimeter bump is considered negative if you test a low-risk healthy hospital worker. A healthy immune system would mount a much larger response to a real infection, so a worker needs a 15 millimeter bump to be considered positive.
Let's hit some ICU pearls and exam traps. These are the things that catch smart people off guard. Trap number 1. The hypoxic drive trap.
Patients with chronic, severe COPD like FT live with a chronically high carbon dioxide level. Over years and decades, their central chemoreceptors in the brain, the ones that normally sense acid and trigger breathing, become completely numb to it. They adapt to the high CO2. They lose their normal, healthy trigger to breathe.
So how do they stay alive?
They switch backup systems. They rely entirely on peripheral chemoreceptors located in the carotid arteries and the aortic arch. These peripheral sensors don't care about CO2, they sense low oxygen. Mild hypoxemia becomes their only drive to breathe. If FT comes into the ER and you panic because his SpO2 is 88% and you blast him with 100% pure oxygen.
You fix the oxygen deficit.
And in doing so, you completely erase his only remaining drive to breathe. The peripheral receptors sense the flood of oxygen, they shut off the alarm, and FT simply stops breathing entirely. You induce respiratory arrest by giving too much oxygen.
Trap number 2, the SpO2 trap. We went deep on this, but it bears repeating.
A patient in severe septic shock with ice-cooled hands who is clamped down on high-dose vasopressors might display a perfectly beautiful normal SpO2 waveform of 99% on the monitor. But if you draw an arterial blood gas, it will reveal profound lethal tissue hypoxia. You must treat the patient, not the glowing box on the wall. Look at their skin, check their capillary refill, look at their urine output, assess their mentation.
This brings us to the core, the intensivist thinking loop. This is how you must structure your mind when you stand at the bedside. Problem: FT has acute on chronic gas exchange failure.
Failing physiology. He has alveolar flooding from his heart failure, pushing fluid into the lungs, combined with massive airway resistance from his COPD and the viral inflammation. This leads directly to decreased lung compliance, stiff lungs, and severe hypoxemia.
Immediate threat. The primary threat to his life in the next 10 minutes is respiratory muscle fatigue, leading to hypercapnic respiratory arrest. The secondary hidden threat is hypokalemia-induced fatal dysrhythmias if we mismanage his furosemide.
Intervention. We initiate upright tripod positioning. Targeted, careful oxygen administration to avoid killing his hypoxic drive. We hold the aggressive diuresis until the potassium is addressed, or we give IV potassium simultaneously. We administer nebulized bronchodilators to break the airway resistance.
Reassessment. You don't just walk away and chart it, you stay in the room. You check the SpO2. You trend the exhaled PET-2O2. You physically re-auscultate the lungs to see if those coarse crackles are clearing or moving up the airways. And you constantly monitor that ScVO2 to ensure his tissue oxygen delivery is returning to normal.
Yes, that constant vigilance is key.
Okay, we have covered a massive amount of ground today. We've gone from the molecular surface tension of an alveolus to the acoustic physics of the chest wall. Let's bring it all home. If you remember only 5 things from this deep dive, write these down. Number 1, core pathophysiology. Respiratory failure is almost always a battle between 2 forces. Compliance, which is stiff lungs, and resistance, which is narrow airways.
Number 2, key assessment finding. Altered mentation and abdominal paradox mean impending catastrophic respiratory collapse. The muscles have failed.
Number 3, most dangerous complication. Attention pneumothorax post-procedure, indicated by a trachea that deviates away from the injured lung or hypoxic brain injury from unrecognized failure.
Number 4, priority nursing action. Sit them up, apply targeted oxygen, and secure the airway first. Gravity is your fastest drug. Everything else comes second.
Number 5, most important treatment. You have to treat the underlying failing physiology. Diuretics to pull the fluid, bronchodilators to break the resistance, and always, always fix the potassium before you push the Lasix.
If we boil FT's entire case down to a one-sentence clinical picture, an elderly COPD patient with heart failure presenting in acute distress with tripod positioning, hypoxemia, and mixed lung sounds indicates combined obstructive and restrictive alveolar failure.
If you see, think, and do. If you see a restless patient with tachypnea, accessory muscle use, and a dropping ScVO2, think impending respiratory failure and do sit them up, apply targeted oxygen, and immediately prepare the team for advanced airway support.
That's the playbook.
We opened today by talking about how much we love the certainty of a clean X-ray showing a broken bone, but critical care isn't binary. It isn't a snapshot. It's fluid. It's an unrelenting physiological cascade.
It definitely is.
I want to leave you with a final puzzle to mull over. We rely so heavily on that glowing pulse oximeter on the finger, and we rely on the patient telling us what hurts. But remember, the visceral pleura, the delicate membrane lining the lung itself, has absolutely no pain receptors. None. A patient's lungs can be drowning in a liter of fluid, tearing from barotrauma pressure, collapsing inward on themselves, and the lung itself feels no pain. They just feel the panic of suffocation. And as we learned with the ScVO2, a patient in deep shock can have a falsely reassuring SpO2 while their internal organs silently die of ischemia. Are we treating the bright numbers on the screen, or are we treating the actual cellular starvation happening in the dark, pain-free depths inside the patient? Next time you look at a glowing monitor in the ICU, listen to the alarms, but then look at the patient and ask yourself, what is this machine not telling me?